Please welcome primary care internist and geriatrician, managing director at Deloitte, Jay Bott, Robert Espinoza, the executive vice president of policy for PHI, and AARP senior vice president and director of the AARP Public Policy Institute, Susan Reinhart, and our moderator, Bryn Bowman.
Thank you all so much for being here today, and it's so nice to be in the same room as you and not thinking about this over Zoom. We're going to talk about workforce trends. We have 45 minutes to pick apart a really complicated landscape. And we've just heard from LaToya Francis, a powerful voice representing a section of the workforce that I think we don't often hear from enough. And LaToya pointed out some of the problems that we cannot deny are the backdrop to this conversation. When we got together and we talked about this conversation, we all agreed we don't want to admire the problems that we all know exist. You read any headlines right now when you think about the workforce caring for people with serious illness. But again, they're an undeniable backdrop. We're looking at a crisis levels nursing shortages. We're looking at record low levels of trust in leadership by clinicians. We're looking at people who feel undervalued in the health system or are not making a living wage. We have a lot of problems and challenges when we think about the workforce caring for patients with serious illness. But again, that is the foundation upon which we make all of our plans for care delivery. So we're gonna have a conversation today with three experts who we're lucky to hear from, who are looking at different pieces of this puzzle, taking different perspectives and focusing on different areas of the workforce, and see if we can't pull out some insights based on the trends that they're observing nationally about where we're headed and where we can put our energies and investment. So I do want to let everybody know that we won't have Q&A at the end of this session to make sure that we get to maximize the amount of time that we have with our panelists, but we are spending the whole afternoon after this panel in breakout sessions, really digging into specific specific aspects of workforce development. So we'll have the conversations in those rooms. So I want to start by asking the three of you, the problems that came to a head when we thought about the workforce caring for patients with serious illness during the pandemic aren't, for the most part, new as of the pandemic. They're problems that have existed for a long time. But what I'm interested in now is, are you seeing any indications that we have reached a breaking point because of the exacerbation of the pandemic? That means we might really start to be having a new conversation about workforce in this country from your different vantage points. So do you see signs that there are major shifts? And Robert, I want to start with you.
Thanks, Bryn. We do see signs of a major shift. We saw, for example, during the COVID-19 crisis, we saw this workforce, the direct care workforce in particular, more and more people interested in who these workers were, what were the challenges they were facing. We saw it, for example, in nursing homes, where that sector was really ground zero for the first 6 months of the pandemic and probably in the long term. And there was an interest in seeing these workers as essential both to the healthcare of this country, but also the economy, just given the role that they played in so many people's lives. Because of COVID relief money, we also saw a pretty significant dedicated funding stream to states all around the country through ARPA. And because of that, states were able to, for the very first time, invest in a wide range of policy supports for direct care workers. However, what we also saw at the same time was that even though the visibility of this workforce amplified, so did the challenges. And so this workforce all of a sudden saw more intense workloads. We saw strain as workers left their jobs and other workers were asked to fill in for those roles. And when we did a study looking at direct care workers and other low-wage workers, other entry-level workers who had been displaced by COVID-19, we asked, to what extent did that workforce come back to direct care once they left? And what we found was that statistically, no one did. And so this is a workforce that is leaving this sector at a time when many of us need that type of support. And as 9.3 million job openings in this sector in the next 10 years alone will need to be filled. The only way to meet that demand is to improve these jobs.
Sounds like the situation has reached such a breaking point that we can't deny there's a problem at this point. Susan, what are you seeing?
So for one thing, it's like not new to everyone now. It's like, oh my God, this is really, really happening, and it's happening in direct care workforce. You've been sounding that bell for a while. We need better wages. But it's happening in nursing, and we've had nursing shortages before, but this is different. This is the new entrance into nursing, or saying, oh, this isn't what I thought was going to be like. You know, during COVID, those students didn't have the opportunity to have as much direct care. They were doing a lot of simulations, which I'm very supportive of, but then they get into the actual environment. It's like, wait a minute, this is wild. My God, what am I doing here? And I have a lot of other options. But there's also physicians. There's shortages all over, social workers, so that it's almost a commonality of, wow, we have to do things differently. We can't just recruit more. We can't just steal from this industry and put them over in that industry. We can't just work about retention. We have to change the work environment, and we can come back to that.
Well, so speaking of changing the work environment, Jay, I'm wondering what you think from your vantage point at Deloitte. I mean, what are healthcare employers thinking about now that they might not have been a couple of years ago?
Thanks, Brennan. Just an honor to be here. I just so deeply admire and respect the work of C-TAC and CAPC, and appreciate all that you do, and just beautiful words from Latoya about where we are from the vantage point of those that are impacted. And I would agree with Susan and Robert about the comments made. You know, one thing I think is interesting is that COVID illuminated that if you're an employer and you have employees, you're a health company. Not just for your employees, but those that you care for, or those that care for you from a caregiving standpoint. And so I think it's that, along with some regulatory tailwinds, along with the economic case, has created, you know, this opportunity to really accelerate how this looks different. And so our research suggests, you know, that we see a trust deficit. 23% of frontline workforce don't trust leadership in organizations. We see this also, that people are expecting more from their healthcare organization. Consumers are expecting more, their families are expecting more. The collaborators that healthcare, the industry works with, community-based organizations, others are expecting more. So that's one. The other I would say is that you know, we haven't had a system that's designed for the preferences and care that people need. When you look at differentiated outcomes, and I, as a primary care physician on the south side of Chicago, see patients where I see the difference with those that have access and understanding versus those that don't. I had a woman I just took care of who has early diagnosis of cancer, who actually has to figure out how she can get images from a imaging center to a health system organization, 3 years worth of images, yet she doesn't have a caregiver, doesn't have support at home, is isolated. It shouldn't be that hard to actually help people get the care they need, navigate what they're doing. And then I would say the economic impact, we've got two reports. One, the cost of health inequities, $320 billion today when you look at race, ethnicity, socioeconomic, and gender differences. $1 trillion in 2040 if we do nothing different. So it is in crisis, and it is urgent. And then the cost of caregiving. The economic impact of caregiving is $600 billion. And so there's clear opportunity for the 51 million unpaid caregivers to be part of a workforce model that works. And to Suzanne's point about it's how leaders behave in organizations, how we do our work, and how we reimagine the workforce that I think can get us to better places. And think about those that are disproportionately impacted. And it's not, you know, we think about older adults, some may organize around age, but it's about those that experience discrimination, poverty, stress, and all the other things that create accelerated aging. And so that's what I see in my clinical experience as well.
Yeah. Yeah. I want to come back to this theme of, so Susan, you're talking about nursing shortages. Robert, you're talking about shortages in the direct care workforce. It seems to me that as we grapple with the reality of those shortages, we're more and more having conversations about the concept of the healthcare team. Who constitutes the team? Who is part of that team? Do you see that concept evolving in the conversations you're having with national leaders these days? You know, what are the indicators that we're starting to change our conception of the healthcare team in ways that strike you as beneficial to patients with serious illness? And Susan, let's start with you.
So team is not new. I think back to like MASH, remember MASH? That was a team. Then we went into primary care where, you know, the nurse did everything. Then we're back to teams. What's different now, I think, is this focus on interdisciplinary teamwork. Not just we're in a team, but you really only still do this and you really still only do that. How do we do these things together? Ideally that we're educated together would be the ideal. That still isn't working as best as it can. But the idea that the physician, for example, doesn't have to be the captain of the ship at all times. It might be the social worker or the pharmacist, particularly in the areas that we're talking about. That doesn't mean, I don't mean to say anything negative about the physician's leadership in many ways, but we have to tune into the expertise that is needed for the patient and the family caregiver according to their needs. And that's a newer thing. In addition, how do you incorporate the family caregiver? Thank you for quoting the AARP Public Policy Institute, 600 billion. Thank you for that. But we have to make sure that, A, they could be paid, right? We could talk about that. Self-direction, we call it, is booming in the states. We have a long-term services and support state scorecard funded by the John A. Hartford Foundation, the SCAN Foundation, and the Commonwealth Fund just released that shows that 35 states have increased in the numbers of, or the percentages that they are using self-direction, which includes family caregivers. So paying is an option, but it's not just paying family caregivers, it's including them in the team and not just saying it, but really meaning it. So when there are rounds on the floors, this is a big focus now, clinical rounds, should have been all along, has been in some places, but more and more so. It can't just be, well, we include the family caregiver if they happen to be there. That's not gonna work. It has to be more planful. It has to be, well, we'll call in when the doctor and the team comes together and listen to them, listen to what they have to add to it and really teach them before they leave, you just heard, teach them if they're gonna be taking tube feedings and what have you, teach them what they're gonna be doing. There is more momentum for that. There's more federal legislation around that. The physician payment codes are changing that you can be paid, not just physicians, but nurse practitioners and others. So to me, that's a growing recognition that the direct care worker needs to be involved in the team, the family caregiver, particularly around serious illness.
Yeah, it struck me as we were listening to Sally talk about her experience. You know, when Walter Jr. was first discharged from the hospital, she didn't know what to look for in the event that he had a seizure. She had a great experience with a great nurse when they went back to the hospital and was told what to expect and what to do about it. That was after an ED visit.
It would have been better if she knew ahead of time.
Right.
Maybe it was in that stack of papers.
There you go. Robert, I imagine you had some thoughts about the concept of direct care workers as being part of a team as you were listening to LaToya talk.
Yeah, absolutely. I mean, I think that I would like to say that it's improved, but I definitely think that in the work that we do, either through our research or working closely with home care agencies and nursing homes and so much more, that too often direct care workers are not considered part of the interdisciplinary care team, and their perspectives, their frontline viewpoints when they spot signs, changes in client's condition, et cetera, it's not transmitted to the team and it's not respected. Oftentimes we work with employers to create these interdisciplinary care concepts, and we don't just train the direct care workers on how to report that information. We train their supervisors and other employees on how to respect the opinions and the perspectives of workers, because they don't often see them as important as other healthcare team members. And so that's a major major change that I think we need to make as a sector. I'll also say I'm always surprised, both as a professional and as a consumer, how rarely systems, how much work needs to be done for systems to talk to each other. And so I'll share a personal story, which is that 7 years ago, I suffered a severe heart attack, and I was discharged from the hospital after about 2 weeks. And I was leading my current role at PHI, and I was living in New York City. And I came home with one sheet of paper that said, here are the people that you might consider contacting, here's the foods you should not be eating, and expect a call from a home care agency, right? And a week later, I received a call and a 20-minute visit from somebody to assess. And it turned out that because I opened the door myself by walking down the stairs, I didn't qualify for a home care worker other than for 20 minutes every 2 weeks, right? And I thought, not to be elitist, right, but as someone in my role in New York City, that I would qualify for a home care worker. A month later, I was back in the hospital for 2 more weeks, right? And it dawns on me that that's a failure on multiple levels. It's about how systems don't talk to each other. It's about the assumptions about when someone goes home, what they have and what they don't have. And it's also a commentary on just the ways in which we haven't figured out yet what to do with people with serious illness who are managing not just the physical effects, but also the emotional effects and the cognitive effects, which was ultimately what brought me back to the hospital.
Jay, are you seeing any bright spots, any positive indicators that we are, at least in some pockets of the health system, understanding how to reorganize teams, reorganize team communication in a way that matches what our patient population needs?
Yeah, I think this is such an important area, and I was reflecting back about these concepts, and it reminded me of the Different Strokes episode where you say, "What you talking about, Willis?" I'm like, these are all things that we've been working on trying to figure out, and I think part of what I see happening as an opportunity is an understanding that people at different places in their training, understanding, and journey as direct care workers or community health workers or family caregivers need different support and different training and different engagement around how you get them to the place where they feel confident, comfortable, and can engage. And so that's one thing I think is a bright spot of saying it's not one size fits all. We've got to say, what are the capabilities we need, where are people at, and what is the right training? Including people, you think about what the education level is, what their level of understanding is. And so I think that's one thing that's a bright side. The other is examples where that there's a real big value between handoffs that happen between people, handoffs that happen between technology, the point Robert's making about being able to talk to each other, but also the handoff that happens between technologies and humans. And given the conversation that's happening currently around AI, I'm I'm concerned that we don't think about equity-centered design and that handoff in the process in which we develop those tools and implement them. We'll have missed an opportunity to do it right and to learn from it and to help people need. And so I think that piece about how humans are involved in those handoffs and help people is going to be important. I'm seeing more discrimination. And then I'm seeing people be part of teams that we wouldn't think about they'd be part of teams. Family caregivers, the barber, the hairstylist, the coach, even kids that may have a perspective that you didn't think about. So I think that we have to think about teams in different ways, and then how we help support teams to be successful.
I want to kind of sit with that last theme and dig in a little bit further. So, the four of us had several discussions leading up to this panel about what were the issues that we wanted to focus on, and I was kind of surprised that money didn't come up very often in those conversations, even though obviously it sits underneath all of this. So I'm wondering, A, is that because it's such a bleak landscape that the three of you didn't bother bringing it up? Or B, are you actually seeing signs that, at least in pockets, money is moving in ways that actually facilitate these new kinds of ways of thinking about team, facilitate better access to long-term services and supports and direct care work? What are you seeing out there that we should all be aware of? And Robert, maybe I'll start with you.
I do see that in the context of direct care, that there are more and more conversations about the financing system behind direct care and specifically behind improving direct care jobs. We saw, for example, when the Build Back Better Act was proposed, that it required at least a $400 billion investment to improve access to home and community-based services, and as part of that, to improve wages for direct care workers. Anybody who's ever sat down with an economist and an actuary to cost out what would it take to improve wages from $12 an hour to $18 an hour, for example, knows that that's a hefty figure, and yet that's where we will need to get to as a country, right? We will need to professionalize these jobs, raise wages to a higher level, a competitive level, and really change the system. We are seeing, for example, more and more interest in social insurance programs and long-term care, similar to what Washington State has enacted, perhaps ideally in the future something at the federal level, but something that would make home care and access to palliative care and hospice care more affordable for people, and that would be designed in such a way that it would transform the jobs of direct care workers to improve wages, to improve training, to create true career paths, and so much more that really elevates the respect and recognition these workers deserve, for sure.
So Jay, you're sitting at Deloitte as the executive director, both of the Center for Healthcare Solutions and then of Deloitte's Equity Institute. And so those are kind of two very different hats with which to be thinking about where money goes in healthcare. Wondering what your comments on this topic are.
Yeah, so I think I'd start with saying that there's design principles around that are important. So the Health Equity Institute and the Center are both integrated and synergistic. So research, insights, and also thinking about deliberately redefining corporate philanthropy and what that is and how we do it. And so for the first time I know of any professional services approach of having community voice be a part of what informs our investments, our research topics, and co-creating with community so that the people that are impacted are really driving what we prioritize and focus on. So I would say the other reason is that we all know that there's a moral imperative to this work. It's incredibly important to do. But we're working to demonstrate that there is also an economic imperative, that a moral imperative has business solutions, and that I referenced our report on cost of health inequities. We did another one this past summer looking at how employers can catalyze healthy aging. And this is really around this notion of, we have a declining life expectancy towards 1987 levels, nearly 76 years. But if we think differently and employers lean in, we could actually get 20 more years of health span for everyone. Health span being high quality of life for the time that you're through life, and not just lifespan, which could be poor quality of life over a longer period of time. And that has impacts economically. It has impacts on people finding meaning in their work and purpose, and what they need to do. So when you ask, what's important to people in terms of quality, it's time for the things that matter to them and what they need to do for others that depend on them. And so even if you think about the examples of self-insured organizations, you could actually redesign and rethink the way you structure and pay for a workforce of direct care workers, community health workers, to support those that may be at risk of very differentiated outcomes because they don't have the support they need. The other example is a consumer-directed personal assistance program in New York State Medicaid that allows Medicaid home care consumers to recruit and hire their caregiver of choice, including family members. So I think that the other point I'll make is we have a system that's very payment first, then care model, and reorient across the board is what are the menu of the right care models that include direct care workers and family caregivers and other kinds of community health workers, and then how do we align the payment to support that, because that'll get us to the best outcome.
Yeah, so important. Susan, I know you think a lot about what's possible at the state level, and Jay mentioned the New York example. Anything else about that?
I just left a conference, a meeting. I serve as vice chair in honesty to the Robert Wood Johnson Barnabas system in New Jersey, a very large system. And they were talking about AI, right? We're all talking about AI and how it might affect how the work is done. And there's a nursing strike, by the way, there. That's public information. Again, staff ratios and how are we going to find enough people, and that's going on around the country. There's no question about it. So where does virtual nursing come in? Where does AI come in? And the speaker was saying two things that really struck me. One was that AI can help reduce charting, can reduce the paperwork. Well, it's not paperwork, it's electronic work. That would be so huge. If you could reduce the burden on physicians, on nurses, on others. For years, this is growing and taking away the attention of direct care providers into actual care, which is expensive. You need more people then, as they're all charting away. That looks like that's going to happen. That isn't like pie in the sky. And if that happens, it's going to be huge, changing how things can be done. The other one was a little more around direct care workers, I thought, which was scheduling, trying to understand where the care is needed and matching workers. You're nodding, so maybe you could add more. Geographically and by diversity, by the needs. It was so much better than just like you go here and then take another 2-hour trip and go over here, which is very inefficient. So I think the efficiency can really improve the care models and therefore the payments. Did you want to add to that? Nope.
Go ahead.
Just that I agree.
That's good.
At least 2 out of 3 of our panel. Jay, did
I'd
you
add to this point too. I think there's an incredible opportunity. I mean, even if you think about all the papers you were talking about, right? Like I wish, so generative AI can potentially help summarize all of that
Exactly.
content and give you the information you need quicker. The other is predictive AI, which is different to say, where are the places most likely to intervene and act on an issue. So I think that those are also important. The other, I would say, is augmented reality intelligence. We've got now ubiquitous with QR codes. I mean, I don't know how many QR codes I see everywhere, but imagine if you actually really gave a patient and their family a QR code that was not a piece of paper with instructions, but was actually you speaking to them about your perspective and experience in an empathetic, respected way with dignity that made it easier for them to even access. So there are ways, again, where I think technology can be an enabler, but we also got to mitigate for unintended consequences, the bias that exists in the existing data, the lack of data and places. But that shouldn't necessarily stop us from doing it. We just have to be mindful of that and create systems that work effectively with each other.
So we're coming, unfortunately, to the end of our time, but each of the 3 of you has influential positions and leadership roles at influential organizations, thinking about how to better support, grow, strengthen, change working conditions for the workforce, caring for people with serious illness. So I want to ask each of the 3 of you, what are you doing and will you be doing over the next few years to contribute to that goal? And Jay, I'll bounce back to you and start with you.
So I'd start with one, every week I try to do the best I can for my patients and their families around the caregiving needs they have. And it requires a team, and it requires technology, and it requires sometimes going to people's homes and bringing people to the place they need. Like that woman I talked about who didn't have anyone and had to get her data to another place. And then for Deloitte and the work we do, I think one, it's continuing to lift up not only the unique insights that can catalyze action among key decision makers and leaders, it's also to demonstrate what's possible. And we think about this through the 4 domains of action. One, what are we doing in our own house with our own people, from family paid leave to leave that and needs that different populations have, and supporting them through that journey. We have a well-being benefit, our integrated mental health services, because mental health is certainly an impact on this issue. And we just released a piece looking at the out-of-pocket costs women pay disproportionately more than men with average benefit design. So even looking at your benefit designs, it's to the tune of $15.6 billion compared to men. And there's a lot of elements to that, but we thought that maternity care would be a big contributor, but in fact it's not. And so caregiving, the experience women have, et cetera. So that's, I think, organization of your products and services. We're equipping our teams. and people to have a lens around equity and around these issues as we think about the problems that are existing with our clients. Thinking about how we support community-based organizations and nonprofits. And then supplier and vendor diversity, that's the ecosystem, and impacting also what's happening in the regulatory policy environment.
Jay, you've been a really powerful advocate for people with serious illness from your time at the American Hospital Association to now at Deloitte. So just thank you for your work and your leadership.
Thank you. It's an honor, and I think the time is now, and if not us, then who?
Heck yeah. Robert, what's on your agenda in the next couple of years?
We talk a lot about the impact and the import of both direct care workers and family caregivers, but what we see often less attention on is the relationship between direct care workers and family caregivers and all the ways in which that can be strengthened. And any of us who have ever lived through a situation where we have a home care worker or another direct care worker working in one way and a family member in another way, we know that when that relationship is strong, the support we receive is strong, but when it's frayed, the support is not. In 2 days, PHI, my organization, and the National Alliance for Caregiver, with generous support from the John A. Hartford Foundation, is launching a multi-year policy initiative that's looking at all the ways in which public policies at the federal and state level can be reformed to strengthen that bond between family caregivers and direct care workers. Maybe it means policies that better integrate both into care teams, or policies that strengthen consumer direction where family members are able to be compensated, and so much more. There's a lot of policies that can be enacted at the federal and state level to do that, and that will absolutely be the focus of our two organizations.
That's fantastic. So we'll all be looking out for that announcement from PHI. Robert, you've been shining a light on a part of the healthcare workforce that has been too much in the dark for such a long time, and it's so exciting to hear about the fruits of that work. So thank you for your leadership. And Susan, what's on your agenda?
So I sit in AARP. Ever hear of it?
I may have heard of it once or
I
twice.
think there's big signs, major sponsor.
Thank you for your help putting on this conference.
The co-founder, Bill Novelli, sitting in the audience, hired me 16 years ago. Thank you, Bill. Still here. ARP, has research, it has advocacy, it has education and outreach. There's a lot that's going on. Relentless advocacy on the part of family caregivers, of course. I don't do the advocacy, I do the research and policy work around that, and that will continue. That's Nancy Lamond, who's the executive vice president of that area, gets her team together every day and says, what did you do yesterday and what are you doing tomorrow? They shake. And then they call us. What are you going to do? How can you help us? So that's. But I do want to mention diversity. It hasn't come up a little bit, and equity, which you did bring up. And ARP has formed the ARP Center for Health Equity through Nursing. And it's built upon something known as the Center to Champion Nursing in America, which Bill and others in the room have been involved, funded by the Robert Wood Johnson Foundation. Again, like 16 years working on that. And we've been working very hard on this to diversify the nursing workforce, moving in direct care workers, licensed practical nurses, working with historically black colleges and universities, Hispanic serving, schools of nursing, Native American, public island, et cetera, and working with HRSA and federal agencies. And the big focus, which is really a niche, believe it or not, for ARP, is finding mentors. We have 38 million members of ARP, and over 1 million are nurses. Isn't that amazing? We just found that out. It's amazing. And so we're reaching out to them, and many want to be mentors. And they, not all are retired. Remember that. ARP is not everybody's retired. That's why it changed from the American Association of Retired Persons to ARP, right? But some of them are, and some of them would like to do more. We're also doing things, and this is a rather new focus. It shouldn't be, but it's around nursing, and it had to do with Cinda Rushton. I don't know if you know, Dr. Cinda Rushton from Johns Hopkins University approached me, and she's an expert in violence in healthcare, et cetera, and she said, we really need you. We need ARP to help with the civility in hospitals. And that, patients and family caregivers are often very hostile to people because they're nervous, they're upset, you know, maybe they had the call bell going and no one showed up right away, et cetera. So we have been exploring that with Johns Hopkins and looking, we wrote a blog, we interviewed nurses. What do you want caregivers and family caregivers to do? If you had your way, nurses, what would you do? And it was, you can imagine, it's listen, it's let's talk. If you have questions, don't assume things, don't be afraid to ask questions. So we wrote a blog about that. It went to all members of ARP, and we're going to continue to see what our role will be and what the role of ARP could be in the shortage. And career ladders, very much so, trying to bring, again, diversity and support. When I listened to that CNA, I could just feel it. You know, it's wages, we know, but it's, she said, what do we want? Listen. That's what she said, listen. And listen to our ideas and help us progress. That's what I heard. Help us progress. So we're taking that very seriously, and it's not only me, this is across the entire organization.
Susan, I don't think there's a facet of this conversation around workforce that we've discussed that you aren't actively working on, and you have just been relentless both in pushing towards structural change and culture change. So thank you for your leadership.
Thank you.
Please join me in giving a big round of applause to our panelists. So grateful to the three of you for being here. Thank you.
Thank you.
Thank you.